Good morning, everyone. My name is Isobel Harrison, and I'm a research nurse on the SINAPPS trial and the PPIC2 study. Welcome, and thank you for joining us on the second presentation of our webinar series for 2021 on the role of inflammation in psychosis. I'll be joined today by my colleague Iona Cairns, who's a research assistant on the trial, and Iona will be chairing the Q&A session after the talk. But before I hand over to today's speaker, I just want to give a few details regarding the webinar. The presentation will last 20 minutes and will be followed by 10 minutes to answer your questions. As all attendees will be muted to avoid background noise, please use the Zoom chat to submit your questions. Should we not manage to answer all your questions during the webinar, we'll collate them in a document which we'll distribute in a few days' time. And please note that this and all other webinars will be uploaded on our YouTube channel and on our website, so they can be accessed at any time. So without further ado, I'm delighted to introduce today's speaker, Dr. Sarah Crisp, who is an NIHR clinical lecturer in Clinical Neurosciences at Cambridge University. And Sarah carries out research in autoimmune encephalitis and is also a neurologist who has almost completed her training. So Sarah will give us a presentation entitled Stiff People and Their Antibodies. Over to you, Sarah.
Great, so thank you very much for the introduction, and good morning, everybody. So I feel a little bit out of place talking to a meeting that's predominantly focused on psychosis, but I think that there are lots of parallels between the clinical questions that I've been interested in, namely stiff people and the relationship between their antibodies and their clinical syndromes, and the relationship between autoantibodies and psychosis. So I hope that this will be of some interest. So we're all interested in immune-mediated neuropsychiatric disorders, and probably first and foremost in the minds of clinicians is to identify which of our patients has an antibody-mediated or immunotherapy responsive disorder. And we can get some way by knowing what sorts of antibodies are present in the individual patient, either in their CSF or in their serum. But we also critically need to understand what relationship those antibodies have with their disease. So whether those antibodies are disease causing, and in what particular clinical situations, if there's a range of clinical phenotypes associated with those antibodies, in which cases they're pathogenic, in which cases they're not. So I'm going to start off with a case just to illustrate the sort of clinical problem that I've been interested in looking at. And this is a 40-year-old man with a previous history of alcohol excess. He initially presented with mood change and hallucinations and was managed in the community. And over a period of a few weeks, he developed increasing limb stiffness. And this progressed to the point that he was completely unable to mobilize at home, and that was what triggered his admission to hospital. On admission to hospital, he had quite florid myoclonus, these really jerky movements. And over the subsequent 48 hours, he developed swallowing impairment, needed to be NG fed. He developed a severe eye movement disorder that was characterized by very restricted eye movements. And he developed respiratory failure and ended up intubated on the intensive care unit. Whilst he was on the intensive care unit, he had these episodes of sweating and tachycardia that suggested quite severe autonomic dysfunction. But quite interestingly, he never really had an overt encephalopathy. So when sedation was lifted, he could interact and seemed to be appropriate when he was asked questions. He had normal MRI imaging of his brain and spinal cord, apart from some very minor brain atrophy that you would expect with his alcohol history. And he had a mild lymphocytosis in the CSF. And this is a clinical presentation that neurologists would recognize as progressive encephalomyelitis with rigidity and myoclonus, or Perm for short. And this is a rare disorder that's characterized by pretty extreme muscle rigidity, stiffness and spasms, myoclonus, hyperplexia, which is an exaggerated startle response, and importantly, brainstem signs. So this would account for his eye movement disorder, the problems with respiration, and the problems with swallowing. Patients can also have a range of other features, so they can have long tract signs, they can have an encephalopathy, they can have severe dysautonomias, and they can have some quite marked sensory symptoms, so things like intractable itching without a clear dermatological cause. And for all the patients that present with this clinical set of features, about half of them have antibodies to glycine receptors, and it's that I'm going to talk about a little bit more. Most patients do respond to immunotherapy, even if they're antibody negative, and this suggests that the antibody negative patients may also have an antibody-mediated disorder. We just simply don't know the target. But often this is a relapsing condition, and patients can also have long-term disability, even if they don't relapse, arising from the first episode. So do glycine receptor antibodies cause this condition? So from the outset, there's a few reasons for thinking that they might. And the first is what we know about glycine receptors themselves. So glycine is one of the major inhibitory neurotransmitters in the brainstem and spinal cord. And you can imagine that if you lost the receptors or they were in some way altered, that if you lose some of the inhibition in the spinal cord, you might end up with excessive muscle contraction, for example. We also have a clue from the observation that some of the signs and symptoms of Perm overlap with the signs and symptoms of an inherited condition called hereditary hyperplexia, in which there's a mutation in the glycine receptor. And it was actually this observation that led to the first discovery of glycine receptor antibodies in a patient with Perm. And finally, and importantly, the antibodies bind to the extracellular domain of the glycine receptor. And that's really important because it means that the antibodies potentially have access to this target without there being prior neuronal damage. So in the bottom right panel, you can see a motor neuron, which is a cell which expresses glycine receptors endogenously. And this has been labeled live with immunoglobulins from a patient, and those are shown in green. And then it's been stained with a commercial antibody for glycine receptors in red. And you can see that at least in some places, the green and red overlap, showing that they're binding to the same target, the glycine receptor. So this is all very well. We've got a good idea that these altering the function of these receptors might cause a syndrome that looks like Perm. But do the antibodies actually do this? And this was work that I undertook in Dimitri Korman's lab in London. And we asked the question of whether antibodies from patients affect inhibitory neurotransmission. So what we did was to culture cells that express glycine receptors. So we took spinal cord from rats and cultured this in a dish, and this is what you can see on the left-hand side. And we made patch clamp recordings from these cells. So the big thing coming in from the right-hand side is a patch pipette, and this is filled with a high iron solution. And this is in continuity with the cytoplasm of the cell. And this means that any time an ion channel in the cell opens, current flows across the membrane, and that can be measured via the patch pipette. And for my experiments, I incubate the cells in tetrodotoxin, which blocks voltage-gated sodium channels. And this means that there are no action potentials in these cultures. But there are still synaptic vesicles located in the presynaptic terminals. And every so often, one of these vesicles containing neurotransmitter spontaneously fuses with the presynaptic membrane and then releases its contents into the synaptic cleft. And when it does it, the neurotransmitter in the synaptic cleft can act on the postsynaptic receptors and cause them to open, and then a current flows. And this can be measured via the patch pipette. And that's what you can see in the bottom trace. So there's a baseline recording, and then each of these downward deflections corresponds to one of these individual synaptic vesicles fusing with the presynaptic membrane and releasing its contents into the synaptic cleft, acting on the postsynaptic receptors and causing current to flow. These motor neurons in culture receive synapses that are not just glycinergic synapses, but they also receive inputs from glutamatergic and GABAergic neurons. But we can block these receptors using a variety of other neurotoxins. And this is an example of one of the experiments that we did. So this was a culture that I incubated in immunoglobulins from a healthy control. We made a baseline recording before blocking the glutamatergic and GABAergic synapses, and you can see these downward deflections in the trace, which indicate synaptic input. And then we pharmacologically isolated just the glycine receptors, and you can see that there's still downward deflections in the bottom trace that indicate that there are active glycine receptors. But when we did the same experiments but incubated the cultures in immunoglobulins from a patient, What we saw was a similar baseline condition indicating that there were synapses present and glutamatergic and GABAergic activity. But when we pharmacologically isolated just the glycine receptors, we saw barely any current at all. And this really strongly says that the antibodies are affecting the glycine receptors and preventing the normal glycinergic inhibitory neurotransmission. And then a final piece of evidence in this story comes from work from Angela Vincent's group. And they have undertaken passive transfer experiments where they took immunoglobulins from patients and immunoglobulins from healthy controls and injected them into mice together with lipopolysaccharide, which disrupts the blood-brain barrier. And the idea of these sorts of experiments is that you're trying to recapitulate the disease in the animal model. And they didn't see a full Perm-like phenotype in these mice, but they did see a motor phenotype. So these mice are on this rod in the center, and the rod is rotating, and the rotations of the rod increase in speed, and eventually the mice fall off. And so this is a measure of motor ability. You can measure how long it takes for the mice to fall off. And the mice who received immunoglobulins from patients are shown with the red in the graph. And you can see that the time taken for those mice to fall off the rod was shorter than the time it took for mice who received immunoglobulins from a control, which is shown in green. So collectively, this all provides really good evidence that these antibodies not only bind to glycine receptors in patients who have Perm, but they do disrupt inhibitory neurotransmission, and they can cause particularly the motor phenotypes that are seen in patients. But what about glycine receptors in atypical disorders? So since their discovery in 2008, there's been quite a lot of cases published in the literature. Initially cases that were similar to the first case of cases of Perm, but over time there's been a wide range of other neurological conditions associated with these autoantibodies. And some of these clearly do relate to Perm, so there's a more anatomically limited stiff person syndromes have been associated in brainstem encephalitis, and some of them are less easily related. So things like epilepsy or neuromyelitis optica, which is a demyelinating disorder. Much less easy in those conditions to see how they might relate to glycine receptor dysfunction. So in Perm, I think we have quite a good explanation of how the disorder arises, knowing that the antibodies can affect glycine receptor function. So we know that glycine receptors are found in interneurons in the spinal cord, which are important in the regulation of motor circuits, and therefore it's conceivable that dysfunction of these circuits would give you rigidity and spasms. We also know that, that inhibitory interneurons expressing glycine are really important in sensory processing, and they've recently been implicated, for example, in the sensory processing of stimuli that cause itch. We also know that descending neurons expressing glycine or releasing glycine are important in the regulation of the startle reflex. And in the brainstem, glycinergic neurons are implicated in the control of eye movements and respiratory rhythms. But what about the more cortical symptoms? So things like epilepsy. And here the story is much, much less clear. So whilst glycine receptors are found in the cortex, they're expressed at much lower levels than in the spinal cord. And unlike in the spinal cord, where the receptors are located at synapses, the receptors in cortical neurons are typically found not at synaptic sites, but elsewhere in the neuron. But there is a little bit of work that suggests that these receptors are nonetheless functional. So if you take hippocampal slices and apply glycine or strychnine, you can see consequences for neuronal firing that suggests that these receptors are potentially active, although their role physiologically is not clear. And they also seem to possibly affect the resting membrane potential. So this is looking at the response to a really potent glycine receptor antagonist, strychnine. And you can see that there are changes in the resting membrane potential when you apply strychnine. And these changes happen in quite diverse brain regions, including CA1 of the hippocampus, but also the nucleus accumbens prefrontal cortex. But exactly what the receptors are doing in terms of physiology is largely speculation at this point. And I think there are a number of barriers to understanding the role of glycine receptor antibodies in these more atypical disorders, or the symptoms that arise in Perm but aren't necessarily part of the core syndrome. And the first is that we're trying to deal with rare associations of a rare antibody, and that really does limit our capacity to undertake either preclinical or clinical studies. As I tried to get across, the roles of receptors in higher brain regions are much less well understood than in the brainstem and the spinal cord, and that makes setting up a function assay much more challenging. And finally, the patients who have atypical disorders often have lower titers of glycine receptor antibodies. And again, this makes the functional studies much more difficult to perform, because if you get a negative result, it's much more difficult to know whether that was because the antibody genuinely didn't have a consequence, or whether it was simply present at too low a titer. And just in the sort of final part of the talk, I wanted to talk about an even more difficult situation for neurologists, which is classical stiff person syndrome. So this is a case of a typical patient, 52-year-old woman who has a 7-year history, so much longer than the first case. Her symptoms started with aching and progressive stiffness affecting her lower back and legs. She has superimposed spasms, which are triggered by loud noises and emotional stimuli. And over the years, she's developed progressive disability with problems walking, falls through which she sustains quite severe injuries. And she has severe anxiety about being out in an open space. And again, normal imaging of the brain and spinal cord. So classical syndrome, in contrast to Perm, you see the muscle rigidity and the spasms, but these patients typically don't have brainstem signs. Psychiatric symptoms are said to be very common, and it's a disease which has an insidious onset, usually in middle age, and affects females more frequently than males. Within neurology, it's a condition which is notoriously difficult to diagnose. There's one study that looked retrospectively at patients who had received the diagnosis, and the median duration from symptom onset to diagnosis was 8 years. And in terms of antibodies, about 10% of these patients have positive glycine receptor antibodies, but the majority have positive GAD65 or glutamic acid decarboxylase antibodies. The response to immunotherapy is also a bit less clear in these patients. So what's very clear from the literature is that patients with stiff person syndrome often do progress to develop severe disability if they're untreated. Some patients respond to symptomatic treatment, so things like diazepam can be helpful, but often very high doses of those are required, and that can limit their utility. And it also, with the progression of the disease, patients usually become unresponsive to the symptomatic therapies. And so immunosuppression is often tried, and this has been the case probably since the late 80s, when the antibodies to glutamic acid decarboxylase were first discovered. And although it's tried, the treatment responses tend to be quite variable. So the best evidence is for intravenous immunoglobulin, and that's based on a small randomized double-blind crossover trial. And that showed benefit in terms of patient-reported symptoms and also some functional rating scales. And then there's also been a trial of rituximab, which didn't show any overall benefits, but again was a small trial, and there was a large placebo effect in that trial. And it's very clear from the literature that there's also a substantial number of case reports which report benefit in some patients with use of rituximab. And then you can find case reports of virtually every other immunosuppressants that we use in neurology with variable effects. What's also clear from the literature, though, is that there is a portion of patients who do not respond to immunotherapy, and these patients tend to have a poor outcome. So if we look more closely at the role of GAD antibodies in stiff person syndrome, we can see that GAD is a very different antigenic target from the glycine receptor. So it's located entirely intracellularly. It doesn't have exposed extracellular epitopes. So the antibodies would either have to get into the neuron somehow, or the target would have to be exposed by prior neuronal damage. It's an enzyme which is responsible for the synthesis of GABA, so you could speculate that if you have dysfunction of this enzyme, you might affect inhibitory neurotransmission. And it's associated with quite a diverse range of neurological disorders, so stiff person syndrome, but also cerebellar ataxias, epilepsy, and encephalitis. So what is the evidence surrounding GAD antibodies in stiff person syndrome? So if you take the antibodies and put them in a test tube with the glutamic acid decarboxylase enzyme, you can find that the antibodies do affect the enzymatic activity and reduce GABA synthesis. But if you apply GAD antibodies to neurons in culture, in hippocampal cultures, for example, those antibodies are not taken up into the neuron. So it's very unclear how the antibody would access the target. And then there's some rather confusing data to suggest that if you apply serum or CSF containing antibodies to GAD from patients to neurons that are cultured or in an animal model in a passive transfer experiment like I talked about for the glycine receptor antibodies, in those cases, there do seem to, at least in sometimes there seems to be an effect on GABAergic neurotransmission. And in the animal models, there are some aspects of the clinical phenotypes that seem to be reproduced. But what's really important about these experiments is that some of them looked very closely to see if the antibodies were actually interacting with GAD, and they could not find any evidence of that. And some of them also looked to see if there was any evidence that there were other antibodies present. And indeed, in some cases, there are antibodies that bind to the surface of neurons. These are clearly not GAD antibodies, but might be an antibody that is relevant to the patient's disease. Again, we don't know the target of these antibodies. So just to summarize, I think that I've shown you that we have really good evidence that glycine receptor autoantibodies are pathogenic in Perm and in stiff person syndrome. But for half of patients with Perm and for most of the patients with stiff person syndrome, we don't really know if they have a pathogenic antibody and what that antibody is targeting. I've talked about some of the methods for and the difficulties in establishing the clinical significance of antibodies. And although I've highlighted this as a difficult area, I think that that it's also quite a hopeful area. And I think that with the studies that are ongoing, both the things like the SINAPPS 2 trial and also the preclinical studies, we're now getting to the point that we're making real progress in understanding this area, which is of clear importance to patients and their treatment. And I also think that we shouldn't forget that the potential that these antibodies and their associated disorders have to inform us about the normal cellular and circuit mechanisms that underlie neurological and psychiatric symptoms that are often actually quite poorly understood. So thank you very much for your attention. I also need to thank the people that have been involved in this work, particularly those that have offered me a lot of support over the years. So Dimitri Kuhlman, Angela Vincent, Thora Karadottir and Alistair Coles. And I'll be very happy to take any questions.
Thank you very much, Sarah, for that fascinating presentation. So we'll proceed directly to Q&As, which will be chaired by my colleague, Iona. Thank you, Iona.
Hello. Thank you so much. That was such an interesting presentation. We have a few questions. The first one is from Belinda Lennox. She said, thanks for a great talk. Is anything known about cognition in those with Perm? There are phase 2 trials in glycine transporter inhibitor in schizophrenia at the moment with primary target of cognition, but maybe different mechanism to that of a glycine receptor antibody.
So I think this is very interesting. So as far as I know, there's not really systematic studies that have looked specifically in cognition in Perm. And I think it is very difficult because often these patients are on intensive care when they're acutely unwell. And there's obviously a lot of things going on. So they're often requiring very high doses of things like diazepam or midazolam to try and control the spasms and so on. So I think disentangling what's a disease relevant effect on cognition from sort of the pharmacological mess that the patients often have at this time, I think would be really challenging. I have been interested to see the work looking at the GlyT2 transporters, but my understanding about that is that it's primarily targeted at so it's looking at the NMDA receptors, which use glycine as a co-agonist. And it's looking at whether you can affect the levels of glycine and thereby affect the sort of glutamatergic transmission through NMDA receptors. So I think that the mechanism that they're targeting is slightly different. But I think that the exact role of glycine receptors in the cortex is extremely poorly understood. And if we're saying that they're acting extrasynaptically, then drugs that actually alter glycine levels more generally, so not synaptic glycinergic transmission, but just the glycine levels might actually be relevant. But I think we'd need to understand a lot more about the physiology first.
Thank you. Another question from Thomas Pollack said, thank you for a lovely talk. Do you think that the marked anxiety we often see in these patients is secondary to the experience of the illness, or is there a more direct, for example, receptor-based or neuroanatomical story here? In my experience, the anxiety in SPS is often way more severe than in other neurological disorders with a similar level of physical disability.
Yeah, so I've been curious about this as well, and I don't have a definite answer. I often rely on the psychiatrist to tell me whether they think it's out of proportion or not. So my experience of these patients is that they often do have falls that are triggered by sensory stimuli, and I think that would be a very anxiety-provoking thing. So we do often have this idea that the anxiety is out of proportion to their physical disability. But I have to say, I'm not always 100% sure that that's the case. And I think that the other disorders we're comparing to is often things like neurodegenerative conditions, which are associated with increased falls. And there, I don't know that maybe the neurodegenerative condition itself is also affecting anxiety. So it could be sort of either way around. It could be in those conditions, the anxiety is out of proportion to their physical disability. So I think it is a difficult area. And again, it's one where we'd really benefit from understanding more about what the receptors are doing in terms of the cortical circuitry, in terms of understanding whether they can per se influence the psychiatric symptoms.
Thanks. It's actually a two-part question. So the next part was also, we've heard of, and in one instance met, SPS patients who've travelled abroad for autologous, I'm not sure that's the right pronunciation, sorry, stem cell transplant with seemingly good success. Is there an evidence base for this?
I think there's a very small evidence base. I think there's one published case series.
Thank you. And then a question from Angela Vincent. She said, given the lack of overt encephalopathy in these patients, how much do they remember of their most severe times, particularly the pain, the respiratory failure, etc.? Amnesia may be useful.
Yeah, that's true. And I think as well, if you add in the pharmacology of being on the intensive care unit, all of the sedation and things like that, often I suspect the very acute phase is not well remembered.
Thank you. Another question, Richard Cole, he says, thank you for the talk, really interesting. I wanted to ask if, given the large placebo effect, would this mean there may be a large functional overlay for some of the patients?
So I think that's something we always have to think about in neurology. So I suspect that almost all of the patients we see do have a degree of functional overlay to their symptoms, and that's across the whole spectrum of neurology, not just autoimmune neurology. And I think that the other difficulty we have in this area is that there are diagnostic criteria for diagnosing stiff person syndrome, but there's no established pathological definition of this disorder, and that means that trying to come up with sensible diagnostic criteria is a little bit arbitrary. And I'm sure that there are people that do get miscategorized. So it may be that among the cohort in different studies, you've got a mixture of different pathologies, and you may even have some patients that have a functional disorder or have a functional predominant disorder. So I think that the large placebo effect is kind of in itself interesting, but I think it probably more importantly says that we just needed a larger study.
Thank you. Just call for any last questions. Oh, lots of thank yous for your answers. I think we're just about at time, so I'm going to hand back over to Isobel. Thank you so much again.
No problem.
We have reached the end of today's webinar. Thank you everyone for attending. We hope you found Sarah's presentation interesting and informative. And we like to invite you to our next webinar, which is 2 weeks tomorrow, when Dr. Esther Coutinho of King's College London will present on the patients who changed the field of autoimmune neurology. Many thanks everyone, and enjoy the rest of your day.